webinar.
Dr. Georgie, you're not sharing your presentation.
Well, here we go. All right. Let's see. All right. Yeah, I'd like to welcome you to this webinar on lumbar radiculopathy, commonly known as nerve pain in the lower back that radiates down the legs. It's a condition that affects millions of people. And today I'll be breaking down its causes and symptoms.
Oh,
Um,
hold on. We're still
but-
not seeing the presentation.
oh, really? I'm sorry.
Your
I see
screen.
it. I see it on mine.
You need to see your screen.
Let me try that again. I'm sorry.
That's okay. We know that it works.
Yeah. Um, just, oh, okay. I see what was done here. Okay.
There we go.
Awesome. Do you see it now still?
No.
Oh boy. Oh, you know what happened? It went on a different screen. That's why. Oh, I see. My bad. Huh?
There we
Okay.
go.
All right. So, uh, so yeah, I'll be breaking down the the causes, symptoms, and diagnosis and treatment options. And by the end of this session, you'll have a clear understanding of how to manage and even prevent this condition. So let's get started. Lumbar radiculopathy is a condition where a nerve root in your lower back is compressed or irritated. You may have heard this term like sciatica. A lot of people like to use that loosely, but it is one type of radiculopathy, but not all radiculopathy is sciatica. Essentially, it's when a nerve is compressed, whether it's due to a disc herniation or arthritic changes, but it subsequently leads you to have pain, numbness, tingling, or even weakness in your legs. It's a common condition. Studies show that about 10 to 25% of people experience it yearly, and it's a leading cause of disability worldwide. The good news is that many cases improve without surgery at times. Understanding this condition is key to make informed decisions about treatment. So, to understand radiculopathy, we first need to talk about the lumbar spine. This area consists of 5 vertebral vertebrae labeled from L1, L2, L3, L4, L5, which support your upper body and allow flexibility. Below is the sacrum that you see down here, and it's a triangular bone that connects to the pelvis. A lot of where our body takes the brunt of like the sciatic conditions happens at the most bottom two. These two are the most common areas that take the brunt of our wear and tear as we age, and or traumatic events that occur. Usually, it'll happen most commonly here, but it can happen in the upper lumbar spine. Between each vertebrae, there's a cushion like a disc that absorbs the shock, and your spinal cord runs uh, through this area here, which we're looking at it in a lateral view and a side view. I'll explain more in a different picture. So, what is a nerve root? If you could see here, this is what I was explaining about the disc and the vertebral body, and here's the spinal cord that sits behind it, where each nerve that comes from the spinal cord exit out this way through each lumbar body, and it has like a road that it takes out this way, out, and it goes to wherever down into the legs, and it does its function of motor function, which is leg strength, and that's where you get the leg strength from, um, and sensation, pain, all come through that route. It's like a wired circuit. So if there were to be a disc herniation, it commonly gets affected um, uh, posteriorly or backwards, basically. So, and I'll explain it in a different slide, but this is where your spinal cord transmits signal and also receives signal. And whenever something like this area gets affected, that's when there's that term sciatica. But we will kind of go on and explain more and learn more about it. So here's a picture of what a disc herniation would look like. We're looking at it in an axial view, or we're looking at it in a sliced view, uh, such as like a top-down view of the spine. So again, this is the disc. This is the spinal cord that we were just looking at before and how it exits out out of the spine, and it goes down into the legs. But when a disc herniation occurs, you see that it can bulge out and sit in an area where it's not supposed to and irritates the nerve that's exiting. And that's how and based off of how the patient presents and how they explain where their symptoms are, how far it goes down, it all gives you clues on which level it may be stemming from. So that's what I can say about that. And there's different types of disc herniations. It could be from a bulge to a herniation, all the way to it to be protruded to the point of it being a term called sequestered, where it leaks the inside of that disc leaks the fragments of the disc, which is like a very serious type of traumatic event that occurred with that disc. So what causes lumbar radiculopathy? There's several causes. We mentioned herniated disc. Spinal stenosis is a common condition that is more so in the elderly population or older folks that have arthritis that causes impingement on the nerve. So when arthritis develops, it develops more bone and it narrows that nerve that exits out of the vertebral body, like I was mentioning before. And that's where it can cause stenosis, which means choking, narrowing that, and also causes irritation of that exiting nerve. And degenerative disc disease is also age-related. And what happens here is that when the disc loses its height in the spine, it will flatten out, and it can also cause nerve root impingement. As it's supposed to sit at a specific height, once you lose the water from the disc, as you get older, you kind of lose that height, and that could also affect the foramen, or the exiting, or the hole where the nerve exits. Other causes, traumas, falls, simple falls, and that's why preventative measures should be taken no matter how old you are. Car accidents, you would see that, and then also things that are beyond your control that could be autoimmune, inflammation, including arthritis. Risk factors are, age between 45 to 64, but that's not always the case. It definitely can happen far younger than 45, far younger. And repetitive physical stress, such as like construction workers or any type of physical manual labor, even, shoveling the snow. that also, these things like that I see a lot. Obesity, smoking, diabetes, and then the physiological factors. Symptoms of lumbar radiculopathy. A lot of patients, start off by saying like, oh, I got pain coming from my back and it's radiating into the legs. And it's hard to describe it, but they know how far it travels down and the way it travels. So, that roadmap of how they're describing how it's traveling down into their lower leg or into the foot definitely tells me where the problem is coming from. And it gives me a huge clue to start investigating further to confirm if that is the problem or not. Patients often complain of numbness and tingling in the legs, feet, and toes, especially at night. A lot of the patients would often tell me that my pain is awful at night, and especially um, at worst, unable to sleep during the night and can't get comfortable and tough time getting up in the morning due to that problem of pain in the leg. And with pain in the leg, there comes muscle weakness, and also it could be muscle weakness separately as a nerve that gets irritated and it gets affected for a period of time. The nerve starts to lose its power on its function, and then you start to see muscle weakness with that condition. Patients would complain of pain worse with sitting, coughing, or bending. They can't sit too long, they have to change position, or any type of cough really sets their back off even more. Um, and then when they tell me how the pain travels, I always refer to this type of diagram, and I show them, does it look like this? Which one does it look like? Does it resemble any of these types of patterns? And it usually does help showing them a visual. At least that's how I do it. And it helps them describe it. And oftentimes it's between L4 and L5. Those are the two that I was mentioning earlier that takes the brunt and the common areas that get hurt. And they would mention like, oh, pain shoots down into my ankle or it shoots down into my foot. My foot feels like asleep. And with that, then I know we're kind of on the right track of where it's located, and then we just continue to work up the case. When you have this nerve affected from the L4 level, you'll have pain in front of the thigh. You'll also have weak knee extension because that's the job of what L4 would do in terms of motor function. And then in L5, pain would be in the side of the thigh, and they would have motor weakness where their foot feels like they can't lift up their foot. And oftentimes they may say that I trip over myself when I'm walking over just a regular pavement or a rug. I find myself too weak to lift up my foot to walk across the room. And S1 is another nerve that can commonly gets affected, where they have pain in the back of the thigh and also have foot weakness. Interesting fact, 75% of lumbar radiculopathy cases can improve within 3 months without the need of surgery, but obviously it all depends on how bad the herniation is. So a good history and being able to listen to the patient's complaint and asking the right questions will lead you down the right diagnosis. Depending on their pain, location, mechanism of injury, or mechanism of how this all came about and how it affects their daily activities. And I usually kind of probe more and say, like, what do you do for a living? What do you do for exercise? And, because a lot of it can stem from that. One time it was an older gentleman that finished shoveling the snow over the weekend, and I just asked him, what were you doing over the weekend? And he was kind of complaining that it may be due to vacuuming because his wife made him vacuum the like the whole first floor, but it was actually due to the shoveling from that weekend. So, having good rapport and comfortability with the patient can really help get you to the right diagnosis quick without wasting or delay. Physical exam, patients would go through a series of exam tests, including muscle strength, sensation testing, and also like nerve impingement testing, which is the straight leg test. And there's a couple others that you could do to test for that too. And that would also be indicative of a nerve impingement or lumbar radiculopathy. Other things, checking reflexes. But after, when I get the next thing is the imaging and tests. I do get an X-ray first. Obviously, an X-ray isn't going to tell you a lot of information, but it does kind of give me an idea of what's happening. Part of it could be, how the bones are stacked up on top of each other. Another part of it is just to see the disc spaces in between each bone, to see where it looks narrowed or lost its height compared to the others. And also like the arthritic changes that happen where you would see the nerve exiting, but you would see that the canal is arthritic and changes. So that just kind of, gives me an idea. It may be such, but MRI is the gold standard. MRI is what gives you the fine details of tissue, disc, how the integrity of each disc space, each disc, and how it gets herniated out into the canal. And the fun fact, an MRI does show herniated discs in 20 to 36% of people with no pain. So if you scanned me, I may have a disc herniation, but it's not necessarily the area that's causing pain. So again, it all has to correlate. So even though you get an MRI and it just doesn't match, it's not that disc bulge or herniation is not the one that's causing the problem, but it is worth noting and keeping an eye on. So here's a picture of what the herniation would look like and see how it affects the exiting nerve. So this is kind of how it looks like in a real picture, but this is what it would look like on MRI. And I wish I would be able to show you more pictures on MRI and break it down, but due to time, this is what I can provide today. What you can see here is the joints of the low back, right here and here. And here's the little bit of real estate that the spinal cord is encased in that little circle, just like what you see right here. And you would see that there's a disc herniation that takes up all this space here where the nerve is exiting. And that would cause a lot of problems, just having it sit just like that. So non-surgical treatment options. The first thing you do is, apply conservative measures such as physical therapy to get them rehabilitated and functional, and applying that, and also using over-the-counter medication or other medications that can help alleviate or mitigate the pain in the interim. A lot of times patients, it can vary. Some patients can present with real acute pain, and some patients can't, depending on how they tolerate pain. Some of them can't tolerate pain at all, and we have to kind of sit and look at their medication profile, medical history, and see how I could be of help, or how providers can be of help to mitigate the pain without causing another problem for them. And with the use of, for example, like corticosteroids. Oral steroids are the strongest anti-inflammatory medication there is. You might hear the term Medrol dose pack. It's a six-day medication course, which does help lessen the degree of pain. But obviously, we wouldn't use that if the patient's a diabetic or has uncontrolled blood pressure. You kind of have to weigh out the benefits versus the risk. But it does provide much more relief than NSAIDs. A lot of patients that I come across are opioid naive or don't want to use, opioid medication, or they're on blood thinners, so you can't use NSAIDs. So the option would be to give, to discuss using oral prednisone or steroids for a short course for that 6 days, for example. I use oral prednisone, the steroid, the 6 day, as like my own personal gauge. So what I mean is, when a patient takes the prednisone for 6 days, I might tell them to come back after the week is done. I might have them return back to the office after a week, especially on the severity of the problem, just to see how things have played out and if there's anything else I could do to be of help, because I want them to get enrolled in therapy and to be able to go through the motions of therapy. Sometimes, I would say like 50% of the patients can't go through the motions therapy because it's so painful. So, then when they say, when I had provided them the steroid for the 6 days, if they come back and they're like, I was good while I was on that medication, and once I finished it, it's back to baseline. So I kind of take that as like a mild, like a moderate problem we're dealing with, as opposed to someone telling me when I took that, nothing, it didn't even work while I was while during the week, it didn't even work at all, and it still is not working. So then that kind of tells me that this is like a severe problem, moderate severe problem. And there's times where I did have patients use the prednisone pack for the week, and they were good during, and they're still good when they came back to see me. So that's a hope that I hope that that ends up happening with most people or all people, but it's not the case. Another medication that is commonly used is the gabapentin or pregabalin. It's a nerve pain medication that helps mitigate the feeling of that shooting pain down into the foot or into the leg. It masks the symptom, but it doesn't treat the problem. And I often tell them, patients, that it's instructive for patients to use it 3 times a day. That's kind of how it's been promoted to utilize it as. I know that it causes drowsiness, which I do highlight. So I end up wanting them to just use it just at bedtime, so they could be encouraged to know that they may have the opportunity to get better sleep. And I just focus on the worst part of the day, which tends to be nighttime. I don't like having them use it during the day, but that's just in me. That's my personal opinion. So those are some of the medications that can be used to help mitigate that pain while they're going through the motions of physical therapy. And also lifestyle changes. So I do spend some time kind of probing, like I said before, and I'll say like, hey, if you're doing deadlifts in the gym, obviously I don't have to tell you to not do that anymore, but just as an example, it's something that I would say, those are the things that I think that may have been the cause. So I kind of want you to just not, work out or not just, or avoid doing that. You could do walking or such, but we'll find out a way to be, me in the middle, and it's comparable. Avoid prolonged sitting. I mean, the pain would be the alarm anyway. It'll tell you to get up. But sitting idle is no good. And when physical therapy is completed or unable to be tolerated after trying for several weeks, then I order an MRI, and then we put it all together, and then from there is where we talk about what the best next step in management is. whether it's depending on how bad the disc herniation looks like and their symptoms, if there's red flags like bowel or bladder incontinence, like things like that that are concerning, and it correlates to the MRI. It will definitely shift my decision making on whether to get a multidisciplinary approach by having one of the spine surgeons in my office be consulted as a consultation, because I treat everybody like family to me, so I don't like to waste anyone's time. If I see that the herniation looks very bad uh, on MRI and it coincides with their symptoms, I would say, listen, I don't want to waste your time. Because oftentimes surgeons have this kind of rule of it's all case by case basis, but if an injection was done in that area, they would delay surgery 90 days because it leads to poor outcome if they were to operate in that area when steroid was used in that region. So with that being said, knowing that may be the case, I would always refer to having them see the spine surgeon in the office, and we together have a plan on proceeding with a route or offering them a recommendation on which way they should go first. So it's nice to have that kind of continuity of care in the office. So if it were to be, if an injection were to be recommended and not surgical intervention, then an epidural injection would be the best next step in management. And an epidural injection is an injection that helps reduce pain by using the corticosteroids locally into the spot where the problem is happening. And it's done under X-ray. It's done in the office. You're awake. You're laying on your stomach, and I would be guiding, talking to the patient throughout the whole time, saying, I'm gonna walk them through it. I'm gonna tell you, I'm gonna numb your skin. I'm gonna use a needle to get all the way to that spot safely. Put anti-inflammatory medication to reduce the inflammation and the pressure that's there. And that really does lay an impact. But the $1 million question is always, well, how long it's going to last? How, and I always tell them, like, it completely varies depending on how bad the herniation is. Because a lot of people may talk to friends and say, oh, he's had an epidural before and that never worked, or they had surgery and that never worked. So it all depends. That's my sticking point. Like it all depends on the problem, but that would be the thing that would be done, and that's something that I do regularly. And it all varies on. It may take one time, it may take two times, but the goal and the objective of this injection is to help with that pain that goes down the leg. So that's kind of what I want them to focus on. And it seems, and at times when there is a moderate problem, after each injection, I have them come back and I reassess them and I ask them the questions, and I go over the zones that I worked on and if that was relieved or not. Because if I focused on one that's like L5, for example, that goes all the way down to the foot, they may come back and say, well, I don't have it going down to the foot anymore. It just stops in my buttock, for example. And that tells me that was a successful epidural injection, and their followed with therapy should continue to help mitigate that pain. But that's not always the case. Surgery. So, some of the things I highlighted before is like if they had a bowel or bladder dysfunction. I remember having this young nurse that worked at Central State, and she was a young mom, disc herniation, and it was a really big disc herniation. And we went through all the steps that I mentioned, PT and all that stuff, and it was recommended for her to try an epidural injection to see how much better she can get. once I got her on the table and had her lay on the table, she mentions to me, by the way, doctor, I was having a tough time going to the bathroom and I can't feel, like I have like groin numbness. I said, oh no, you have to go to the emergency room because that was a quick, emergent surgery that was needed because of that term, cauda equina syndrome. And thank God it was in the back of my head. I remember that in med school and residency and all that, where, I never had to, come across that before, but it was like those buzzwords that told me. And, thankfully she went to the emergency room. She had emergency surgery to decompress that area, and she's all better now. So that's all those years of med school. Uh, So indications for surgery is that one that bowel and bladder dysfunction, which is a red flag, or progressive muscle weakness, and if the severe nerve compression. I mean, it all will add up on exam, and how if if all those conservative things was not successful. The surgical options that are widely given, but it all depends on the situation, is micro discectomy, which basically they take a bit of disc out with a minimally invasive to remove some disc to get that off of the nerve that's being compressed or irritated. Laminectomies is definitely a very big um, uh, and like successful surgery. They would take a piece of the lamina, which is the back of the bone of the spine, to open up that space more, which is successful for folks, especially for that term stenosis. Spinal cord stimulation. So spinal cord stimulation is something that I do. It is like the last resort type of thing that's offered when epidurals or short-term relief. Surgery is not an option, whether it's they're contraindicated to have surgery or they don't want to have surgery. Spinal cord stimulation is a very like an amazing modality treatment that has been like kind of really revamped and at its top of its peak in technology on knowing how to mitigate pain in especially when there's like nerve root compression. Um, Fun fact, surgery is often last resort. 75% of herniated disc resolve within 2 years naturally. Um, Not sure about that one. I have to see what article that came from, but if you are really focused on preventative measures and learning how to just continue to strengthen your core and all that, with time it can revert back into the place that where it once was. Preventing lumbar radiculopathy, maintaining good posture, lifting objects properly, strengthening the core and back, quit smoking because that does cause degeneration. And a fun fact I learned is, driving with like truck drivers or bus drivers that have that vibration exposure can increase the risk of radiculopathy. So that's all I got for today.
Thank you so much, Dr. Georgie. I am going to open it up now to questions for anyone that has any questions for this evening. And if you don't have, and if you can write them in the chat, and then if you, after this presentation, have any other questions and they come up to you, feel free to email me, Jamie Jordan, at the Arthritis Foundation, and we can definitely get them to Dr. Georgie for you to be answered.
Thank you.
Also, feel free to bring yourself off mute.
I guess I answered everything adequately.
You were really thorough. I mean, I learned a lot, and we appreciate you sharing all of your knowledge and, this evening, and we really appreciate it. It was really great information, and thank you so much. Please feel free, everyone, to reach out if you have any questions. And thank you so much for joining us this evening.
I appreciate your time, folks.
Thank you.
Thank you.
Thank you.
Welcome. Bye for now.